Did you ever think in residency, when we're having fun, working our asses off, but at the same time enjoying our each other, friends? Look where we are now, man. Look what the world has brought us. And it's not just us, it's all of us as medical professionals. I have seen surgeons step up. I've seen cardiothoracic surgeons go into ICUs and becoming ICU attendings. I'm seeing it in your institution. Mm-hmm. And that's the beauty of this all, because it's binding us as one thing, the word doctor. It doesn't matter what specialty.
It really doesn't anymore.
And we're here for each other, and we're going to get through together, period.
Yeah, like tomorrow I start nights. I am on with a cardiology fellow. I'm on with a neurointensivist. And the other attending at night is a cardiac CCU.
We love critical care medicine because we save lives. But what was the unexpected thing that you weren't either trained for, expect when it comes to this disease, or even in your training didn't expect to learn or know before these last 2 weeks, 3 weeks?
Everything about the disease is just like every week there's something that happens that is new and that's different. Everybody says this is ARDS, but like the way they behave, the whole physiology doesn't sound like ARDS at all. Like, it's only the fact that they require a lot of oxygen support that correlates with ARDS, and the X-ray and the imaging and everything, that looks like ARDS, but the physiology is very different. So what is unexpected is that I'm just waiting there in the room for like half an hour, 45 minutes, waiting for the saturation to go up. And I keep changing around my in the first week I tried to do that. I kept changing around the ventilator settings, and I thought I'm doing something. But half an hour later, after being in the patient's room, I would leave with the same ventilator settings that they were on before when I went in, when they were actually having a low oxygen level. The other thing that's so very different about them is that they can be looking so good, and any kind of agitation, any kind of work of breathing, it's just this, and they just drop their oxygen level, they start to work. Like I just saw a patient, it was like last week when I saw a patient and she was talking to me. She was working a little bit. Normally she would not be in a regular medical floor, but the times are different right now that we have to triage which patients are coming to the ICU. All she did was, they were saturating about 91, 92% oxygen with a mask on. I left, I thought she was okay to be on the floor because she was talking to me. She's like, no, I'm fine. I think I was freaking out a little bit, and that's why maybe, I was breathing hard. Half an hour later, there's a rapid response that is called on her because all she did was she went to the bathroom. She comes back and she's breathing at 50 times a minute and she's saturating 75%, which is very, very low for these people. And then you try to calm them down and try to give them some medications. Sometimes we have to just give them some morphine just to take the edge off, see if that works.
Yeah.
Sometimes it works, but some of them who are already that decompensated, when they're breathing at 50 times a minute, it really doesn't work. The only option out there is to just put them on a ventilator.
Can you please tell me on the grounds, ER to ICU picture that you've seen?
So 18 years and above to whatever age people are living in, they're all at risk. I've taken care of patients in my ICU who are younger than me and who have been the sickest people that have been there in the ICU in this last 2 weeks. So I've seen every single decade. I've seen a patient from every single decade in my ICU. So I'm sure that on the floors, there are much more than that out there. And yes, comorbidities and advancing age are higher risk factors for mortality. But that doesn't mean if you're young that you're not going to get this disease. And if you get this disease, it's going to be mild. That's not how this disease is working. I don't think it's picking and choosing as much. What we're also noticing them is that some of these patients are having increased risk of blood clots, whether they're in the legs or they're in tiny or in some of the organs where they're having very tiny, what we're calling as microthrombi. Putting them on blood thinners, when you start noticing any kind of change, especially renal failure, is something that we're seeing. And the other thing that is really hampering us a little bit now is that they are very, very delirious. We are seeing the delirium as a reason for a very difficult extubation. we're seeing the delirium as a reason for reintubations because they get delirious. We try to control them, then they get really agitated. They work themselves up, and when you work yourselves up, they become hypoxic.
And we're doctors in different fields, and we all have a role to play. And what struck me the most is you're just doing your job.
Yeah, that's the bottom line. You're just doing your job.
Cheers to the healthcare workers, all of us, everybody in that hospital that goes to work voluntarily. Cheers, bro.
Cheers. This is water, but yeah, cheers.
Yeah, it's coffee, whatever. I love you. Good night.
Good night, man.